almost afternoon, everybody. This is the liveliest luncheon I think I've ever attended. It's nice to hear the din and see the smiles. And this is such a lovely venue. I can't believe in all my years in the Northwest I haven't been here, but it's nice to see all your happy faces. My name is Manda Factor. I'm the co-host of Seattle's Morning News on Cairo News Radio with Charlie Harger. Absolutely love what I do because I get to come meet people like you. You might say, wait a second, I thought that girl was on that other state. I was for 23 years and just got to Cairo about a month ago and thrilled with my new home for many reasons. One, it afforded me the opportunity to be here with you today. And as a woman of a certain age, I'm going to sit down because my alarm clock goes off at 2. So sometimes I confuse this time of day with dinner. So I'm sitting down. Not many things would take me away from my early afternoon nap, but this is very important to me for a number of reasons. And one is, as I said, I'm a woman of a certain age. And I had a lot of questions about getting older and menopause. And I'm just curious, did people in your family talk about menopause and what happens to your body and what happens after menopause? Because in my house, no. Anybody? No. Raise your hand if you talked about menopause before it happened. You did. That's awesome. My mom didn't. I knew about hot flashes, but that was about it. So this is why we're here today. Was that really only one hand? That was only one hand. Okay, this is why we're here, because these are things that need to be talked about. Another thing I think about a lot these days is anxiety and depression and stress, just because there are things that I hadn't dealt with before. And a lot of people are just struggling because they're feeling these feelings for the first time, whether it's the stress of raising kids and taking care of aging parents. You know, you've heard of the sandwich generation. There's a lot going on in the world and a lot that we need to talk about. And that's why I'm here today. So thank you very much for having me. We're going to, at the end of the program, we will save time for some questions from you. So please jot down notes while we go through the program if you'd like. And we'll come around with microphones when we wrap up the presentation on the stage. So let's go ahead and get going. This is going to be very informative. And again, I hope to get some questions that I wish I had had about 10 years ago. Right now, I have the privilege of introducing someone who has been instrumental in advancing healthcare and supporting conversations like this very one. Her name is Dr. Elizabeth Waco. She is the CEO and president of Swedish Health Services. Please, Dr. Waco.
I was trying to sneak and come around the side, and she called me out on it. Well, thank you all for coming. I am so excited to see all of you here today. I think this is probably one of our best attended events, and I love attending events that are all women because we're strong and we're stronger together. So I love that you're all here. So thank you for coming, and thank you for joining us for our inaugural Women's Health Education Series. This is the first one, and you're here for it. So thank you. So we have lots of aspirations as Swedish of really being destination healthcare for women. From adolescence to birthing to menopause to healthy aging, we want you to be able to seek your care here at Swedish. And we feel like for a very long time, women's health has been somewhat ignored. And you laugh, but it's so true. So if you think about it, we didn't even include women in clinical studies until 1993. 1993. Is that not the wildest thing you've ever heard? Clinical studies formally started. So if you think about the first double-blind gold study, it would have been in the 1940s. So 53 years. And before that, don't think that they weren't doing studies. They were doing lots of studies on men, but not on women. So this is a priority for us as an organization. And I would say our journey started in 2018 when we formed the Swedish Gynecology Specialty Center. I just call it the Swedish Gyne Center. And in that center was really a place where women could get care for menopause. They could get care for pelvic health and sexual health. And that program it's where I get care. And it is also a program that we're planning on expanding so that you can get additional services like primary care, women's heart, women's brain, women's healthy aging, all in that one center. It's a center for us. And I would like to acknowledge Dr. Tanya Sorensen. I'm looking at her. So Dr. Tanya Sorensen, and you should applaud. She is our medical director for Women's and Children's Services. She runs the Institute. This Gyn Center was actually her brainchild. I remember her talking to me about it. I was the chief medical officer in 2015, and you were talking about it. And when I think, if you say Dr. Niels Johansson is the father of Swedish because he founded Swedish, I would say Dr. Tanya Sorensen is the mother of Swedish. Because I will tell you, when I had my first hot flash, the person that I ran to was Dr. Tanya Sorensen. And I was like, this is unacceptable. So Tanya hooked me up, got me in the clinic. I'm sleeping at night. I think I'm doing relatively better. Could maybe lose a little weight. So maybe we'll hear a little bit about that. But if we could solve the problems of roots, I would love that. Because you know what? I mean, it only does so much. And I feel like this is the one thing that really just like isn't covered. But you know what? These women are amazing. I think they'll come up with a solution for us. Okay, so today we are here with the first in the series for women's health. And so really, this is an educational series. We want to leverage the expertise of our physicians. We want to champion health equity through education. So you having the power to make decisions for your own healthcare, we want to be able to give that to you. And so joining us today are our task force members. So these are the women that put these series together, that put this group together, and that created this event for you. So the first is Meredith Beatty. Meredith. And wave when I say your name so we can see you. Pat Hackett. Pat. Woo-hoo. Jane Halligan. There you go. Lori McDonald Johnson. Lori, thank you. Jamie Shanks. Carol Westland. Becky Wilcox. There you are. And last but not least, Dr. Diana Perkinson. And Diana is amazing. Having recently retired, she is a legacy Swedish physician. She just retired from her private practice, and we gave her a little award for that. She is a wonderful physician. So if you have a chance to talk to her afterwards, give her some congratulations, because I would say she's moving on to the best phase of her life. So thank you, Diana. So I do want to go a little bit off script to say, as I was reading through those names, I realized that many of these women, and actually many of you in the room, when I came into my role, pulled me aside and thanked me and encouraged me and said I was the person to be in this role. And I cannot thank you all enough for that. I mean, you don't get a lot of thanks in my role. You don't get a lot of encouragement. It's not like anesthesia back in the day when my patients would hug me when they woke up because they didn't think they were going to wake up. I'm not getting that. So you all have just been so incredibly supportive, and I appreciate it. I appreciate every time you pull me aside and say that I'm doing a great job. I appreciate the support in ways that you probably cannot comprehend. So thank you for that. Okay. I am going to call out a thanks to all the donors to the Swedish Gyn Specialty Center. Without your support, it would not have been possible. You really are creating a future where women feel heard, they feel supported, and they feel cared for at every stage in their life. So the two physicians you're going to hear from today, amazing physicians that I know very well, Dr. Dina Gordon, who is the medical director for our Gyn Specialty Center, and Dr. Enrica Basilico, who is a board-certified obesity medicine physician at Swedish Weight Loss. So with that, I'm going to turn it over to Amanda Factor to begin our conversation. Thank you for being here, and I hope you find this discussion enlightening.
Okay, let's get started. If I could have the doctors come up. We're about to learn a lot of things together, and I'm really looking forward to it. think mics are on. We'll ask a softball question just to get us going in case we have any nerves we have to settle. I'm just curious. Let's go ahead and get going. You guys ready? Yes, let's do it. So, Dr. Gordon, easy question, but important. We want to get to know you a little bit better. What inspired you to pursue your particular specialty?
So I have always been interested in science and health, and also basically immediately fell in love with women's health when I was in medical school. The opportunity to be a part of these major life transitions that we go through, as well as just getting to educate and empower women, has always been a passion of mine. And I was a generalist OBGYN for about 10 years when the opportunity to move more into menopause medicine came my way. And it really is the heart of all the things I love about being a physician. Just, it's really special, and getting to partner with people and make decisions about the next decades of our lives is exciting every single day to me.
And Dr. Basilico, how did you end up where you are?
Well, my background is in internal medicine and primary care, and I've been doing that for a very long time, 25 years at this point. And in about 2016, I started to become more interested in metabolic health. I really wanted to understand, what was the biology around weight gain? What were the factors that, contributed to weight gain? And so I kind of pursued that, and I got board certified in obesity medicine, and I ended up transitioning to full-time obesity medicine. I think another reason why I wanted to do it is because I do think that a lot of patients who have overweight and obesity face a lot of bias in our healthcare system, and I wanted to be part of kind of improving that and give my patients kind of evidence-based care and the opportunity to get healthier, which is really what we're trying to do for everybody.
As I mentioned, we never talked about menopause in my household growing up. I knew hot flashes, but I had no idea, like Dr. Waco, I had no idea it was going to feel as though I were self-combusting. It was awful. Thank heavens I'm on the other side. But everyone knows what a hot flash is, especially if they've been through that. What other kinds of symptoms bring women into your clinic?
So many.
Yeah, you need all digits to count the symptoms of menopause.
Well, you mentioned earlier anxiety, right? So mood changes are really common in perimenopause. Sometimes it's as simple as just not feeling quite like yourself. Other times it's rage. I have a patient who told me she was getting so angry, a physician actually, so angry sitting in traffic on I-5 going to the hospital that she, on more than one occasion, intentionally crashed her car into the wall of the parking garage. Maybe I shouldn't say that in front of the people in charge, Dr. Waco. But I mean, that's an extreme version. I think mood changes are a big one though. Sleep disturbance, joint pain. I think we're starting to understand more this musculoskeletal syndrome of menopause, right? So frozen shoulder might be the classic, but lots of people, some people are even incapacitated by muscular and joint pain in this phase. The genitourinary symptoms are common, libido changes. I could probably go on, but I will also say certainly weight gain is a common one, and one that's really frustrating for people.
Oh yes, weight gain. We were having lunch before everyone arrived, and I was eating my awesome salad. I hope you're enjoying your lunch. It was delicious. But when we were talking about weight gain, obviously this is a concern during menopause and in the years after. And my question as we were having lunch back there was, why? Why does it happen here and here? I don't understand. It hurts. So talk a little bit more about what's really happening with a woman's body.
Well, I think that it is really common to gain weight in menopause, and they say typically about 1.5 pounds per year, and it can be average. Not 70% of women, I think, will gain weight in menopause. It may be even more than that. So if you think about the menopausal transition lasting roughly 10 years, that potentially is 15 pounds. It's a lot of weight that can occur. And especially if you already have overweight or obesity, that any significant weight gain can really kind of change things. And we think that it has to do with the decrease, the kind of redistribution of adipose tissue, fat tissue, and the reduction of lean muscle mass. We think those are the biggest driving factors, and it has to do with lowering our metabolic rate. So we burn less calories at rest as we go through menopause. I also think that, or not I, but it also seems that aging is part of it, right? A 10-year period is 10 years. That's, we burn less calories as we get older. And then there are some studies that say also that women in their 50s spend less time being physically active. They participate less in leisure activity. So, changes can occur through that period where you're less active than you used to be. And there are so many things that might be pushing that. For instance, all of the menopausal symptoms can really make it hard to be as active as you might have been before.
Can you talk a little bit more about redistribution, as you call it? Because I'm curious, it seems to happen in the same place for so many women. Is there an answer for that?
So you're saying why?
Why here?
Yeah.
Why here?
Yeah.
It's not normal. My
Well,
pants don't fit, and I could do 500 sit-ups, and they still aren't going to fit properly.
so we gain visceral adipose tissue, right, around the waist, and I actually don't. I don't know. One of the things that we still don't understand is how. We know it's normal, it happens, but is there an adaptive part of it, right? Some weight gain may be protective. It's not that all weight gain is actually unhealthy. Of course, when you're having too much adipose tissue around your organs, we know that can be associated with metabolic disease. So I guess the answer is why there? I don't think I have the answer why there.
Should have started testing before 1993, huh? Maybe we would have some answers. What about the hips? What's with the hips? That seems to be another thing that always hurts. I mean, what happened? My body was hijacked. Is that just because it's a joint? Is it?
I think it really is mostly abdominal. And so
Yeah.
it's got to, weight's got to go somewhere. It's going to go everywhere, right? But
Yeah.
yeah.
So let's talk about, Dr. Gordon, hormone therapy, because it has evolved quite a bit over the years. What do you recommend and what do you not recommend?
What a big question. I mean, it's really individualized. Not everybody is going to go on hormone therapy.
I guess what types of therapy are there and how do
Yeah.
they differ?
Yeah. So, I think that we are still, I think as many of us would acknowledge in this field, learning. There's so much to learn, right? To Dr. Waco's point, women have not been studied nearly as much as we could have, should have been. And there's more research happening all the time. And so, I gave a talk last year and I said, in a year from now, we might be saying something differently. And I think that that's true today, right? In a year from now, if we're at a similar event, I might say, well, now we know this, that, and the other thing. So right now, what I'll say is, the big money maker here and the big feeling maker here is estrogen. Estrogen doesn't do everything for us in our bodies, but it certainly does a lot for us in our bodies, right? We have estrogen receptors all over the place. And I think, we've started cataloging more and more symptoms that are related to menopause that nobody has acknowledged. I see patients who've gone to the ENT 1,000 times for plugged ears. And they're like, how is plugged ears a symptom of menopause? Well, it is, right? Our skin, our gut, all parts of our body are impacted by changes in estrogen. And we're only scratching the surface of what estrogen does in our brain, right? How our brain is impacted, how our brain evolves and adapts on the other side of menopause. I didn't mention brain fog, right? But that's a really common reason.
Oh, we'll talk about that later.
Yeah, we will. We'll get there. Don't worry, everyone.
If I remember.
And no, you don't have to mention. Right, exactly. Exactly. So, first of all, I tend to say, right, I've heard someone else say this, I agree. The goal is preserving our functionality, right? And helping us age in a healthy way where we can feel like ourselves. We're not going to live forever and our bodies won't always be exactly as they are when we're 20 or 30, but to feel like we are in our own skin, like we can do the things that bring us joy and like our bodies are functioning, we should get to feel that way. right?
Yeah.
And estrogen is the key thing that helps with that for a lot of people. Um, you know, the Menopause Society is pretty rigid in who it recommends estrogen for. It says it's there for hot flashes and night sweats, vasomotor symptoms. It's there for bone protection. It's there for genitourinary symptoms. But what about all the people having severe joint pain? What about the people whose brain fog might be improved from estrogen? And so, recommends a strong word, but I will always have a conversation with people about what are your symptoms? Where's the data? What do we know estrogen's really good at? It's really good at mood in perimenopause. It's not proven to be great at mood after menopause, but we have that conversation and then we make a decision about, is this the right thing for somebody? If you have a uterus, you always need to have progesterone if you're taking systemic estrogen, because progesterone keeps the lining of the uterus from getting too thickened and forming a uterine cancer. So if I'm giving somebody an estrogen systemically, so not necessarily a vaginal estrogen, right, for dryness or urinary symptoms, but if you're taking estrogen on the whole and you have a uterus, you need to take progesterone. Fickle friend that progesterone sometimes is, but, or frenemy. And then there's testosterone, which is a controversial character and very popular at the moment. It is rare that I tell people they ought to be on testosterone, but for some people, it can really be helpful. And we have a conversation about the pros and cons of it.
Popular at the moment. Why do you say that?
It's having a big moment on social media,
Huh?
and there's a lot of influencers, and it's being studied, right? I mean, I think for many years, and we don't know that much about it. So we'll see over time what we have around data about it. For many years, we told people you should never take testosterone. There's no data around it. And women were asking for it for libido. And we, the medical society, I say, said, no, we don't have data. But it turns out for some people, testosterone helps libido, right? And so it is this balance of how women feel, what our experience is, what we've been given access to, and the data lags behind the reality of what actually we might know to be true or
What-
experience to be
What's
true.
the alternative for women who simply can't take hormones?
There's a lot of alternatives, and the conversation is really around what are the symptoms we're trying to navigate, right? So what we might use for hot flashes might be different from what we're going to use for, say, I don't know, if somebody's got insomnia. So there are a number of non-hormonal treatments, and they can range from not medication, but actually cognitive behavioral therapy is very good for sleep, right? So everything from CBTI to there's some evidence around hypnosis to medication options that might target hot flashes or vaginal symptoms that are not hormonal.
Dr. Basilko, when we're talking about weight loss, you said testosterone is really popular right now. Well, weight loss drugs are very popular right now. The Wegovys and the Ozempics have really taken the world by storm. Can you explain how they work and who should be taking them?
So, GLP-1 receptor agonists are a class of medications which are used to treat diabetes and obesity. We've been using this type of medication for since 2005, so they're not as brand new as a class of medications. But of course, in 2017, Ozempic was first approved, and I would say since then there's really been a huge increase in using these medications to treat obesity as well as diabetes. Actually, we have many more patients now who are on these medicines for diabetes. The way that they work is that GLP-1 is a hormone which we naturally make when we eat, and it is a hormone that signals to our brain that we've eaten. So when we are taking this medication, we have stronger messaging to our brain, which says, you've eaten, you're full. It also works on the gut, and it delays gastric emptying. So it slows down how quickly food goes from your stomach into your intestine. And then finally, it works on the pancreas, and it works on the pancreas to increase insulin secretion when you eat, and also to decrease glucagon. So it also helps with blood glucose management. And so when you take these medicines, you feel fuller, you think about food less, you stay full longer, and you have better glucose management. That's how they work.
Dr. Gordon, can someone be on hormones and also one of these Tell me again what they're called. GLP-1s?
Absolutely, yes.
Yeah, so they're indicated for people who have obesity or people who have overweight with comorbidities. So that means, that we generally use a BMI criteria, even though really obesity is better defined by looking at your proportion of fat versus muscle. But in general, we're usually using a BMI, but we're trying to get a sense of, do you have, because you can have a very high BMI and be all muscle, right? But in general, these are, guidelines that kind of work for most people. So that's who that we use them for. We don't recommend using GLP-1s for non-clinical,
Yeah.
non-clinically meaningful overweight or obesity.
Do you have any concerns about how popular they've become?
No, I mean, I guess I
As
think
long
it's
as they're used in the right way.
correct. I think it's great that people understand that there's treatment for obesity. They are 3 of 6 medications that we have that are approved to treat obesity. So I think that increased awareness is going to be helpful for a lot of people, and I think that their popularity is I hope going to increase their access, which is a big challenge for most people.
What happens when someone stops taking one of those drugs? How do you help them with long-term success?
Yeah. So whenever we're using any medication to treat obesity, we're really using it as kind of one arm of our treatment, right? So no trials to treat overweight or obesity, and no recommendations are ever, hey, take this drug, see you later, because everybody is always being encouraged to try to eat a healthy diet, to remain active, to work on changing behavior. So really, what I say to my patients is, all the things that you do to lose weight, you have to keep doing to maintain weight loss. And that includes medications like GLP-1 RAs. So the answer is at this juncture, we don't have enough data to support using these medications to help people to lose weight only. We have data that supports using these medications long term, because when you stop the medication, then biology wins, and biology wants you to gain weight, like across the board. It doesn't respond well to weight loss. Your metabolic rate slows down and your hunger hormones go up. So you stop taking a medicine, which is helping manage the hunger, and you seek more food. And that's biology. It's not about willpower.
And Dr. Gordon, clearly exercise plays into this, but the way we exercise certainly changes over the years, doesn't it?
It does. I think that we heard sort of in our 50s, it gets hard to be active, but we generally encourage people with age that strength training is really important for maintaining bone and muscle mass. I was just having this conversation with a friend on the drive over here. I'm going off script, guys. About the reality of life and what health looks like, though, right? And so it's, we'll talk all about protein and strength training and these things helping us maintain muscle and weight and health. But I think there's so much out there about what does health look like and how do you stay healthy? And when you think about cardiovascular health and brain health, I mean, sometimes it hurts my brain trying to think about, but I'm supposed to eat the Mediterranean diet, but now I'm supposed to have protein, but I need to be lifting weight, and it's like moving and living our bodies in ways that feel good matters, and I think there can be a season for walking if you can with a weighted vest, right? That's strength training. I mean, it's not going to build your muscle mass, but it's good for your bones and it's good for your heart, right? It's about balancing all of these different aspects of who we are as people to try to obtain find wellness for ourselves. But yes, things can change with time. I mean, and if you stay healthy and if your joints work, right? I mean, there's so many pieces that go into it.
I'm sorry, I keep checking my watch because I know we have limited time and I know you guys have places you need to be later, but we do have 2 more big topics I want to cover. I also want to remind you that if you have questions, please feel free. When we wrap this up, we'll come around, just raise your hand and someone will bring a microphone to you and the doctors are happy to answer your questions. So here's an uncomfortable one that no one wants to talk about, at least I don't, but we have to. You brought up libido. Explain how things are changing and what we can do to feel better.
Yeah, I mean, the conversation I have around libido is always the sort of start with it's complex, right? Libido for women, it's complex and it's multifactorial. And I think my own perspectives on this, the more and longer I do menopause care, the more patients I take care of, are to say there's absolutely a hormonal piece to this, right? So, it's certainly there's stuff out there about duration of relationship, getting bored, right? I mean, it doesn't happen to men in the same way as this data says it happens to women. The load of things we're carrying. So, someone else already brought up sandwiching, right? If you're anxious about the world, if you're stressed, if you don't have time, that affects libido. So, yes, there are a lot of things that go into it. But then certainly there are patients for whom they hit perimenopause or menopause and their libido changes. I think there's a lot we still don't know. I mean, I have a patient who had a thyroidectomy for thyroid cancer who told me one day she had a libido and then the day after her thyroidectomy, she didn't. And no one will listen to her about finding the ideal range of where her thyroid should be. And I think there's a lot we still don't know.
Yeah.
But certainly there are hormonal pieces to libido. And I talk about how estrogen is a sex hormone, and so is testosterone. And both of those things are normal in our bodies. And so we don't know what everybody is going to respond to. There is no one size fits all approach. We know that couples counseling and sex therapy can absolutely help some people. Even just the focus on the relationship is part of what can help build connection, right? There's things like scheduling sex, which is not the most fun, but women can, if they are, I mean, I'm not joking, right?
Yeah.
There's the studies on sexual response cycle kind of suggest men have to be interested to become aroused. That's not necessarily the case with women. And many of us want to feel interested and initiate sex, right? It makes us feel like ourselves for some of us. Everybody's libido is different, I'm just going to say, right? There's no normal. And it's only a problem if it's a source of stress for you or a source of tension in your relationship, right? It's normal for things to wax and wane. But also sometimes hormones are the answer. And sometimes they give people estrogen and their libido comes back. Sometimes it's not until a higher dose of estrogen after everything else feels the same. And this is not science backed. This is my anecdotal clinician experience.
We like it when you go
Under
off
the
script.
radar. I know. You guys didn't know you had me up here about to bring everything up. So I find sometimes, right, if your hot flashes are gone and you're sleeping better, that's like the minimum bar. We give a little more estrogen and libido starts to wake up. Doesn't always, sometimes it does. Testosterone, the data says sort of 1 to 2 more satisfying sexual events a month for a postmenopausal patient. Is that enough? I don't know. But I think also we want to feel better. And sometimes testosterone, we buy in, and I don't really care if it's a placebo effect. If someone feels like their life is better, if we're being safe and managing it appropriately, sometimes there's a role for that. But I have that conversation with people, right? I'm not going to say this is absolutely going to fix things for you.
Sure.
And I think we're going to learn more over time.
More testing. Dr. Basilico, do you have anything to add on this topic?
Libido?
Yeah.
No.
No. I just wanted to give you a chance, but I don't blame you. That's Dr. Gordon's specialty. All right. Just in the past few minutes, Dr. Gordon, you used the word stress. We are all feeling a ton of stress. And I have always been a pretty laid back person. And then menopause hit, and I'm like, yeah. So if we could just spend a few minutes talking about stress, anxiety, how to deal with it at this particular season of life. Whoever wants to go for, actually, do you want to go ahead, Dr. Basilico?
Sure. I mean, I think stress is really common in all periods of life, and definitely there is something about menopause. I am a very practical person. I like to go back to basics. I mean, the first place that I think is really important to think about when we're thinking about stress is sleep. I know that is, it's a very strong menopausal symptom. It's certainly a symptom that, sleeplessness, insomnia can very much affect your weight. So I want to focus kind of on, getting back to basics, how are you sleeping? Again, for weight, it can, insufficient sleep can affect your hunger hormones. It decreases your satiety hormones, and it also makes you more likely to want to eat for pleasure, right? Because you're looking for reward because you're tired. So I try to look at the basics, and then we do try to use just evidence-based treatment, CBTI, cognitive behavioral therapy, but and validation, right? What you're not crazy, what you're feeling is normal, and this is what we've got to help you.
Oh, I don't feel normal sometimes, Dr. Gordon. So, what do you have to say on this stress and anxiety topic?
Yeah, I mean, I think I agree with everything you said. We also know that estrogen levels affect our brain, and our serotonin and dopamine receptors are impacted. And so there's also a real impact of that shift in hormone and how it affects our neurotransmitters. Um, so, I think absolutely sleep, therapy, all the things that we do to help us stay grounded. I also want to call out that folks, the biggest predictors of having depression or anxiety in menopause are similar to the other times in our life, having a prior episode of a mental health challenge, and especially around a hormonal transition. So often when I see somebody, I'll ask them, how was postpartum if they were postpartum, right? How, if they've had a prior episode of anxiety or depression, that often surfaces again during this other hormone transition, right? The fluctuations in hormones are just extreme. So in perimenopause, giving estrogen is just as effective as using the SSRIs. And so often, if a patient's gone to their primary care doc with multiple symptoms, or their OBGYN or whomever, and their primary care doc has offered them an antidepressant, that's still the most effective treatment for depression or anxiety generally. But estrogen can be just as effective, and sometimes both are needed, and sometimes they work synergistically together. So I think keeping in mind that hormones are a key component, and can really help. I think the data, like I said earlier, about that mental health shift on the other side of the menopause transition is a little bit less clear. I think people are looking at testosterone and how it impacts cognitive function and mental health. We don't really have all the information yet. But sometimes hormones can help with anxiety after menopause. It's not data driven, it's not scientific, but I think for some patients it's meaningful.
Just one more thing before we get to questions. Get those questions ready, and Shyla will come around with a microphone. But I'm sitting here listening to myself going, oh yeah, that's hot flashes and my hips are killing me and I'm stressed out. And I must sound like a miserable person to you. I'm not. You just deal with it. But you mentioned brain fog. And there's another thing where I'm going, yeah, that too. How do we deal with that? And that is normal?
So brain fog is a really interesting one. I tend to think of it as this umbrella of many possible pathways, right? So sometimes brain fog is hormonal shift, like estrogen, but sometimes it's poor sleep quality, right? Or an emergence of sleep apnea that someone may not know that they've had, right? Affecting how well and deeply they're sleeping. It could be that they have depression, right? That can cause brain fog for folks. It could be an unmasking of ADHD. It is becoming increasingly common for, I see some head nods around the room, right? For women who have been able to mask or just not have the same impact from ADHD, kind of enter perimenopause, the change in hormone fluctuations and the impact on our dopamine receptors and a variety of other things. Suddenly, we have ADHD, and giving estrogen for what we think is hormonal brain fog, which it may be, doesn't fix that brain fog. When that happens, I'm always suggesting to folks, like, you need an eval for these other possible things because there might be a different treatment that's actually going to improve your brain fog. The data we have says that sort of the perimenopausal brain fog that's hormonal will improve on the other side of that hormone fluctuation. Our brains don't recover exactly how they were, but because we are strong and amazing, and brains are strong and amazing, we do develop some other areas of our brain that were maybe not activated beforehand that are compensating. And so a lot of people will feel less foggy on the other side. They might not feel exactly the same as they were, but it does get better.
Dr. Basilico, anything to add? Don't say no.
About brain fog?
Yeah.
I mean, I think it's really common, and I think that common and it should be addressed, right? I mean, again, I think that thinking about so many of these menopausal symptoms, women are often undertreated. We know that, right? And we also know that women with obesity are even less treated than other women. And we know that increased, I'm going back to weight, right? Because,
That's your thing.
increased menopausal symptoms is actually also associated with increased weight gain during the during the transition. So, these symptoms are all normal, but that doesn't mean that we have to necessarily, that we have to suffer through them. And I agree with Dr. Gordon that, patient that we need to listen to our patients and figure out how these symptoms are affecting their life. And whenever we make a decision about starting a hormone treatment or any an anti-obesity medication, if somebody has obesity, you're making a decision about what the pros and the cons of the treatment are, and that's kind of how you approach it. And so, there are a lot of things which are low risk, right? We know that going to the gym is very low risk, right? It takes a lot, but there's a lot of things that we can do to try to improve symptoms, and we just need to keep listening to people and hearing what they're experiencing and do more studies.
Yeah, I
right?
truly believe knowledge is power, and I'm thrilled by the fact this is happening right now, and something just like this is happening in another state. It's really becoming a nationwide movement. And if you have any questions, now is the time to ask. I've learned, I know I did plugged ears. Really? Who knew? I learned something. So please, if you have questions, raise your hand and we'll get a microphone to you. I know there's one in the back. Shiloh, did you find somebody? Okay.
Hi there. So my question is for some of us that have maybe already gone through the hot flashes and didn't go on estrogen, and so now we're on the other side of it and we're shrinking and we're going through all that. What would you recommend?
Oh, yeah, the shrinking part. I forgot about that.
Well, if in terms, so you've survived the hot flashes, right? Or, you survived the hot flashes, you got through the sleep disturbance. I think that, obviously, interested in what Dr. Gordon would say, but I think that then our next thing is, right, how do we preserve our brains, right? We want to preserve our brains. It's one of the things we care the most about. And so again, I'd follow the evidence, exercise, weight-bearing exercise, weight training. And the recommendations are for really quite a lot of exercise. I mean, if you look at what is recommended, it's 150 minutes a week and twice a week with weight training, and you have to add Tai Chi and Qigong 3 times a week, right? There's, now they've added a balance proportion, right? So it's quite a lot of exercise, but if we think about how that can really help us while we age, I'd say if there was one thing that I would want, that I would recommend, it would be to move your body.
And Dr. Gordon?
Yeah, I think that makes a ton of sense. And yes, I think it's also what symptoms are you still experiencing, if any, and how do we monitor you, right? Because we know that the hot flashes, if they were extreme, can be markers for future cardiovascular disease. And so are we sort of staying as aggressively on top of the remainder of your health issues as possible, and having conversations about, right, what the options are?
I wonder about the safety and efficacy of plant-based hormone replacement therapy as it compares to pharmaceutical. Thank you.
Yeah. So, in general, the best I can say about that is no product is ever 100% safe that we're going to use, right? Nothing is guaranteed in life. In general, we now have high quality, regulated, kind of bioidentical medications that we can use that are estradiol, which is similar to what we make on our own, and the same with the progesterone, that we can prescribe, that we can follow the quality of, that we're never guaranteed wouldn't have some sort of contaminant in them, but it's traceable if there's something that goes wrong with it. And there's not the same out there about plant-based or compounded medications. and they haven't been proven to be superior in any way. And so I tend to say, if we can get you something that is prescribable, that is trackable, that is regulated, that we know is less likely to have contaminants, that tends to be what we recommend.
Lots more questions. Excellent.
This is so fascinating. I'm learning so much. Thank you. So I had breast cancer when I was quite young, and so I've actually been on an anti-estrogen pill for many years. Still am. And is there? I'm starting to really get concerned about memory and all that. Is taking testosterone or any? I mean, other than the cognitive, theories that are or some of the procedures that you're talking about or methods, are there any pills you can take, whether it's testosterone or anything else that can help if you can't deal with estrogen?
Such a good question. So first I want to say that most people now agree. I know you didn't ask about vaginal health. I'm partly using this because I didn't bring that up around libido, and now we can touch back to it. It's generally accepted that estrogen is fine to use vaginally, at least, which isn't necessarily going to help your cognitive function. But in terms of part of our life and our well-being, your bladder function matters. It's like also your bladder function matters. Right? I see people out there being like, well, maybe it will help your cognitive function.
It's like a slow motion reaction.
Are you sure you want me to be in charge, Tanya?
Yes.
Here I am. Anyway, there is a pilot study that looks at testosterone in breast cancer survivors. And I think, one of the challenges about testosterone is in high doses, it can convert in our bodies to estrogen. And so we don't know how much could we give you without increasing estrogen levels. We don't know long-term about testosterone specifically in cognitive function, if it could be beneficial. And so I would say, there's a little bit more coming out now where people are kind of asking about testosterone for folks who've had hormonally sensitive breast cancers. And I think we're going to learn, but we're not there yet.
All right, more questions? Yeah. Thank you.
As far as hard data that we can bring into a doctor, what would you recommend that we can do from home if we don't have that in place with a physician? Like, is there anything that we can keep track of that we can bring into our doctor specifically? Or is it just repeatedly going into the doctor and having the conversation?
I guess I would say if you're repeatedly going into your doctor and having the same conversation,
You're going to be funny again, aren't you?
No, well, I don't
You
know,
need a
maybe-
new doctor?
I would encourage you to think about why your doctor is having the same conversation with you, right? I mean, is it because you have active contraindications to hormone use, which there are very few, right? Or is it just that they are not there are still doctors who are really anxious about hormone therapy, right? Who trained in the era where Women's Health Initiative made us pull everybody off of hormones, and where they're still nervous about using them or still sort of thinking about the risks of them. I mean, it's interesting. We don't read women the riot act about using a birth control pill for contraception. Birth control pills probably carry a little bit of risk for breast cancer, right? And yet we don't say you can't take this hormone because it might give you breast cancer. And then suddenly we talk about menopause, where it's not about having sex sometimes. And we suddenly make people really scared. But I think that, medicine, it's slow to change and culture is slow to change. And so it's okay to think about going outside the care of your current doctor, right? Finding a menopause specialist or asking if there's someone else or why they're so against it. I think one of the challenges is periods don't change until very late in the process of perimenopause. Hormone levels don't change often until very late in the process of perimenopause. So you may be having symptoms for a really long time that may or may not be tied to your cycle, and often are tied, but your cycle might be doing some slightly strange things. And if you go to your doctor with this data about your periods or your, or ask
To
for
get your
more.
hormones checked, it's not going to help.
It's not going to help because
It's not
people are
gonna
just
help.
going to say,
They're going to say your hormones are changing all the time. It's not going to help. When was your last period? 2 months ago. Okay, I'm going to fall asleep now. Was it a year ago? No, it wasn't. So you have to talk about symptoms, and that's probably what I would recommend. Tell them what your symptoms are, and say,
yeah,
could these be symptoms of perimenopause? Could these be symptoms of menopause? That's probably a good way to.
and it's even reasonable to say, well, what's the downside of me trying some hormone, right? To see if it makes things better.
Good question.
Could you just talk a little bit about how philanthropy plays a role in the women's clinic?
Yeah, I think that Dr. Waco touched on it in a lovely way at the introduction, but I'll say, I'm sitting in front of you today because of a group of women who were asked to sit around, donors, who were asked to talk about what was missing in their healthcare, right? What was needed in the space in Seattle. And out of those conversations came midlife care and aging care, right? We have babies, and then there's not so much for us in terms of care focused on our needs. And so it was through this focus group or series of focus groups that the idea of creating a space for menopause care was born. And in fact, from the time it was started to now, right, we've grown, we've moved spaces. Our first space was possible because of donors. Our current beautiful space, if you haven't seen it, you're invited to come and see it, right? There's now 5 of us providing menopause care, in addition to a few other specialty GYN areas, all kind of housed together under one really lovely roof. The way that we are able to grow and continue to grow has been because of the foundation and because of donors. I want to specifically call out Pat Hackett, who's here today, and also Jane Halligan is here today. And then Jolene McCaw and the Apex Foundation. Jolene's not here today, but they're not the only ones who made our space possible, but they certainly had a huge impact on making our space possible. So thank you.
Hi, my name is Marcia, and my question is, you've talked a lot about healthy people going through menopause and dealing with weight loss and stuff. And my question is, what about those of us who have been navigating disease for decades? I've lived with multiple sclerosis for 27 years. I've been on a disease-modifying drug for 27 years. I thought, is this menopause? Is this MS? Or, what is this? The weight loss? I've been to Weight Watchers for decades. What's this happening in my midriff? And, my question is, are these weight loss drugs safe with disease-modifying drugs? Or how can you navigate disease too with all of this?
Yeah, so at Swedish weight loss, we are taking care of all different types of people, and in fact, I would say the majority of our patients do have medical disease. We know that obesity itself can increase your risk, but we also know that there are diseases which just the treatment of those diseases increases your risk of weight gain. So, breast cancer is as an example that came up is the treatments we use to treat breast cancer cause weight gain. So the GLP-1s are actually, just specifically to answer your question, and many of the other anti-obesity medications we use are safe to be used in people who have what we would call other medical conditions or comorbid conditions. In fact, they've been studied in people who have metabolic associated liver disease, which can lead to cirrhosis. They've been studied in people with cardiovascular disease. They've been studied in people with sleep apnea, and they have been studied in arthritis. So generally, these medications are really well tolerated, and they don't interact with most other medications. So it's one of the reasons why they're popular is because a lot of people can take them, and people actually have, there is some emerging data that they themselves have an anti-inflammatory effect. So, still, I would say jury's still out, but a lot of people actually can have improvement in symptoms related to those other diseases just because of the medication and probably also the weight loss.
Thank you for your question. I think we need to wrap it up there, but I have asked the doctors 10 minutes. Could you stay back if anyone has a question they're dying to ask? Okay. Yes, thank you. That's it for questions. So thank you for having me here. I'm super thrilled. And I told you, Lorna, this was going to go by so fast. And it did, because there is so much to talk about. So I would like to say thank you for the doctors. So if you aren't going to talk to them again, we appreciate you. And for those who don't know, this is Lorna Neeland, the Philanthropy Director for Women's and Children's.
Hear me? Wonderful.
can.
Well, thank you so much for being here. Thank you to our doctors. Thank you to Amanda. Did everyone find this informative?
Yes.
Yes, yes. I'm Lorna Neeland, as Amanda said. I just was calculating. I've been a part of Swedish for 19 years. And this has just been a very special place for me and many others. And I just wanted to thank everyone for being here. Dr. Elizabeth Waco, our CEO, thank you for kicking us off today. We at the Swedish Foundation have the lovely pleasure of working with many of you donors here. I'd like to acknowledge our Chief Philanthropy Officer, Greg Simpson, our male, in the room tonight.
Oh, man.
And then my lovely colleagues are just around the room. So if you can just give a wave, it's just a pleasure to work with all of my lovely colleagues. So our Women's Health Task Force, this is a group that helped design, curate, and invite many of you here today. So I'd like to thank Meredith Beatty, Pat Hackett, Jane Halligan, Lori McDonald Johnson, Jamie Shanks. I'm like, where's everyone? Carol Westland and Becky Wilcox. Thank you so much. Thank you for being here. So this is the first one. We're going to have a next one in the fall, so we hope that you'll join us. Your feedback is very important to us, and so we will be sending you a survey this week, and we ask that you fill out the survey. We'll have areas of focus that you can check the box on, and so please be very candid with us. And like Dr. Gordon said, the Swedish Gynecology Specialty Center was created because of many of you here. And so Pat, Jane, and Jolene, thank you again. Thank you.